So update, what are the new about the APS-GN, acute post-streptococcal glomerulonephritis or acute post-infectious GN, or an it is possible in other infection GN, IRGN. So glomerular structure alteration by autoantigen along with this previous tier of immune complex disease in situ formation are said to be the newer things is possible. Third histology is possible. Your L-port is different from the others from the diffuse proliferative GN, and membranous GN is possible in the hepatitis B, HBV, tuberculosis, malaria, and filariasis, and the FSGS is possible in endocarditis. Garland pattern histology of APAGN is more often associated with the proteinuria. We know that there is a small subset of the APAGN do have nephrotic proteinuria. There can be 10%, even 25%. So it's possible, and some reports says it's 2%. What about the presentation like? Complete histological resolution may take place here at 1 year or so. Those who do not, they are regarded as something different, commonly C3GP. The presentation was same. Basically, why they didn't recover, because there is complement disactivation, continuous complement disactivation leading to the C3GP, which is the same sort of presentation, low C3, low SO2, high SO titer. Thereby, they had this sort of clinical course and renal histology. So gross immature of simple APHGN can have recurrence after exercise or intercurrent infection. 90% of the APHGN can have subclinical course, so it's quite high, and they go unnoticed. Now can have some sequelae, may not have some sequelae. Subclinical cases are said to be 19 to 57% times more common than clinical cases. So another newer entity over here is a posterior reversible leukoencephalopathy. Previously we called it hypertensive encephalopathy. This was not true. In fact, nowadays they say they are not the hypertensive encephalopathy. They have something else apart from the hypertension. So incidence of those cases are 0.5 to 10% of the hospitalized patients. It is apart from the hypertension, they do have the CSF protein elevation. There are little bit of the vasogenic factors is there. So and your blood biochemistry alteration may have contribution over here, and cerebral vasculitis can be also factor in these simple APHGN cases. So differentially, same mechanism, same presentation is possible with IgA vasculitis and rheumatic fever. So and the child presenting with the nephrotic presentation APHGN, they do resolve by 2 to 3 weeks. So persistent of 3 weeks, this sort of presentation in APHGN means severe kidney insult. They can have long-term bad outcome. Concomitant disease of the APHGN are your IgA vasculitic, Hanoch-Schulin purpura, your lupus nephritis, diabetic nephropathy in a bit grown-up child or adult, and bilateral hypodysplasia, that is low nephron endowment, is also a common. And then your ITP. These are the few entities commonly said to be associated with the APHGN, and why they are associated: autoimmunity mechanism, and glyceraldehyde 3-phosphate, and then NAPLR, the plasmin associated your antibody, said to have long lasting, more than 10 years even, effect. So this antibody lasts in the serum. That is why a child with APHGN do not have second infection, recurrence of the disease. Thereby, it's said to be protective, and the level of this NAPLR, is 92%. 50% cases do have higher NAPLR, and they give protection. So it is a measure of protection, and basically it is raised in the A and C group A streptococcal infection. Also, it is raised in 60% of your group A streptococcus infection without nephritis. So keeping in mind the newer things, the APHGN declining entity throughout the globe is taken into consideration. Biopsy and other immunosuppressive use. So nowadays they say Group of PSGN patients do have crescent. So those cases need immunosuppression. The IV methylprednisolone, if followed by by MMF, maybe a little bit of cyclophosphamide and other immunosuppression until disease is quiescent. So these are the newer addition, newer entity, newer science with the acute posteptocal GN, and maybe true for other infectious GN also.